This is Sami Inkinen, CEO and co-founder of Virta Health. And most importantly, welcome everyone to our two-day virtual conference, Moonshots for Health, with a specific focus on reversing America's chronic disease crisis. And I think, as some of you know, this is actually already the third consecutive year of the Moonshots for Health conference. And we're very excited to have you all here. In fact, I was just looking at the numbers, nearly 5,000 people have registered for this year. So it should be an exciting couple of days here. As you heard, we have a very impressive and I would say insightful group of panelists and keynote speakers here. But let me briefly first explain, what do we mean by moonshots? What is a moonshot? Well, moonshots are the opposite of what typical healthcare innovation looks like. And in fact, our friend Dr. Sachin Jain, who is also the CEO of Scan Health Plan and speaker in this conference, recently wrote a Forbes column about the difficulty of innovation and how incremental everything is in healthcare. And you can see the title of his column on this slide. And basically, Dr. Jain very eloquently described in his column how during his medical residency, he noticed that patients at his hospital often had a ton of questions to ask to their providers, but during the rounds, when the provider came to the room or the nurse came into the room, the patients basically forgot what to ask. So he had this, frankly, a great idea in my mind of just giving a notepad to each of the patients, a notepad and a pen, so each patient could write down their questions. And so when the doctor would come to the room, they could just read their questions. But according to Dr. Jain, even this, what I would consider very incremental innovation, it died in the decision and approval process. And it basically never was implemented. I can imagine how frustrating that would be. Can I have the next slide, please? So what are moonshots? So with moonshots, we want to do the opposite, the absolute opposite of incremental innovation or innovation that dies in a decision-making process. So what is moonshots? Think very big, very transformative, at least for the next 2 days, and worry about the implementation and approvals later. So that's the kind of thinking we want to encourage with moonshots, and hence the title for this conference, Moonshots for Health. Okay, so briefly, what do we have in store after the keynote that we have in a couple of minutes? Next slide. I'm going to cover or describe the 4 key sessions that we have coming up after the keynote. First one, reversing chronic disease through new care models. Next one. Then, in search of health equity, from ideas to reality. I think health equity is a topic that everyone has been and is thinking about, appropriately so, in US healthcare. So we are trying to actually go a little deeper in this session. Next one. Third one, how to combat the pharmaceutical cost crisis. Last one, please. Innovative care solutions for older adults. So these are some of the sessions that we have over the next 2 days, and I can tell that the panelists that we have are absolutely fantastic, talking about these 4 topics that I just described. And speaking of amazing panelists, our keynote includes 2 amazing chief medical officers. So I want to briefly introduce my 2 keynote speakers here, and then we'll go into the questions that I'm going to be asking them. First, we have Dr. Susan Fleischman, who is the Senior Vice President and Chief Medical Officer at Blue Shield, California. And Dr. Fleischman has had an extensive career in healthcare space and previously held executive positions at Kaiser Permanente and Anthem, which of course today is called Elevance as well. So welcome, Dr. Fleischman, and thank you for being here.
Thank you. Happy to be here.
Fantastic. And then also we have Dr. Dora Hughes, who is the Chief Medical Officer of the CMS Innovation Center at the Centers for Medicare and Medicaid Services. And Dr. Hughes also previously held leadership positions at the U.S. Health and Human Services and helped implement the Affordable Care Act. Equally big welcome, Dr. Hughes. Thank you for joining.
Thank you. Thank you for inviting me.
Yeah, so let me start with an easy, hopefully easy question to you both. And it's basically, what is your moonshot goal? What is your moonshot goal? And just for context, at our company, my company, Virta, our moonshot goal is to reverse type 2 diabetes in 100 million people. So I'm very, very curious, what is the moonshot goal in your respective organizations for transforming the lives of your members or beneficiaries, and especially those who are living with chronic conditions? So in any order that you want to go.
I'll start. So we also have a very bold and ambitious moonshot. We at Blue Shield of California want to transform the healthcare delivery system. Our North Star is care worthy of family and friends and at an affordable price. And so how are we going to get there? We don't think we can get there through fee-for-service medicine, through the healthcare system as it is currently structured. So we want to move to pay for value, and not pay for value where we're just pushing risk down, but where we are actually paying providers to do the right thing for our members who have chronic diseases, including diabetes. You know, I practiced in the safety net for 20 years, starting 30 years ago, if you can believe it. It was before there was an internet. And we knew back then what to do for diabetes. I mean, we knew the kind of tests people needed. We knew that they needed to have their eyes checked, to follow their kidney function. And yet here we are so many years later, and many Americans with diabetes, they don't get Virta, they don't get disease reversal, but they don't even get basic care, the right tests ordered, control of their disease, and preventive services. So our goal is to change that by transforming the healthcare system. We think that's the only way we can get there.
Well, fantastic. It sounds like the pace of movement and innovation is a little bit like described in the Dr. Jane's column, but hopefully you can accelerate it. How about Dr. Hughes? How do you look at what's your moonshot? You're looking at the entire country, obviously, not just California.
Yes. Although California, in some ways, it is its own country, and so I will certainly stipulate that from the start. I love Dr. Fleischman's opening comments. We're certainly very much aligned with our focus on value. Just very briefly, for those of you who are not familiar with the CMS Innovation Center, we were created as part of the Affordable Care Act in 2010. Our statutory mission is to improve the quality of care while reducing the cost of care. And in about 2020, 2021, we look back over our performance over the first 10 years to think about what have we learned, what have we achieved, what are some of the challenges, ongoing challenges that we still hope to address. And as part of that, we came up with our 2030 goals for the CMS Innovation Center. Our moonshot statement, if you will, is a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And to unpack that a little bit more, we have 5 pillars within that I'll describe very briefly. The first, and this is definitely a moonshot goal, is that we hope by 2030, 100% of Medicare beneficiaries will be in relationships with providers that are defined by accountability for the quality of care and the total cost of care. So I feel like whenever you start with 100%, that is a moonshot in and of itself. But the other 4 pillars are also just very critically important. Our second pillar focuses on advancing equity. You touched on that in your opening comments, and that is absolutely a top priority for our center as well as CMS as a whole. We want to focus on transforming healthcare through modern technologies and tools and learning supports for our providers. The fourth pillar focuses on affordability, both at the systems level, how do we drive down costs and waste, but also at the individual level. How can we lower costs for individual beneficiaries? And certainly, I think diabetes is a poster child in terms of high cost treatments and diagnostics and care. And so it's just very important. And the final pillar is partnership. Cadre of providers and hospitals and health systems and plans that have worked with us. But we also want to make sure that we are increasingly engaging beneficiaries and other advocacy groups to make sure that we're, as we move forward, all of our work is informed by the person-centered perspective. So with that, I'll stop. Happy to dive a little deeper as we talk more.
Yeah, well, thank you both. It sounded like there were a lot of similarities. Obviously, quality of care, total cost of care, health equity, many similarities from both of you. So, Dr. Hughes, let me dive a little bit deeper into. You also mentioned technology and telemedicine. So, specifically, I think many people know that policymakers have extended Medicare these flexibilities for a bit longer. But we may need to permanently reconfigure access to telehealth services to take advantage of the new care delivery models and some of the things that we saw during COVID. But given the skepticism in Congress, is CMMI now contemplating additional models to study the effectiveness of novel telehealth approaches? Or how do you guys look at telehealth and technology and kind of what we learned during COVID and what might need to or should happen in the future?
Now, that's such a critical question. I think what we learned through COVID was how important it was to have full telehealth capabilities, and also how we were fortunate that how fast we transformed to adopting more telehealth capabilities across a variety of healthcare settings. And so at this point, we're trying to think through, even as we're emerging from the pandemic, which of these flexibilities in terms of, particularly in terms of how we pay, should we maintain moving forward? That's true for our models, but it's also true across CMS, whether you're thinking about Medicaid or Medicare, which of these flexibilities should we maintain? And very importantly, which of these flexibilities do we have the authority to maintain? And unfortunately, those two is not 100% overlap. So this is a very active conversation. I think in the weeks ahead, you're going to hear a lot more about what we're able to do. For us, in terms of our models, though, we increasingly are providing infrastructure funding upfront or advanced payment that can support adoption and use of teletechnologies. That's particularly important for some of our smaller providers, those that are lesser resourced that may need more assistance in investing in telehealth capabilities. So certainly we're not retreating. We are certainly moving forward. And I expect in the coming weeks that you'll hear more about what else we'll be able to do.
Can I just make a comment on that? This is unscripted, but the silver lining of COVID, which, is a horrible illness and people continue to suffer, was the rapid adoption of telehealth. And think about that slide that you showed from Dr. Jane with the slow progress. We saw our network overnight almost adapt to telehealth. And interestingly, we saw our behavioral health providers go first. They realized they could see their patients, they don't have to do a physical exam, that they could use, tools on their phones. They went first. And guess what? Our members really liked it. They could get seen in the privacy of their home. They didn't have to drive somewhere. And we saw the rest of our providers follow very rapid pursuit. I've never seen adoption out on the ground in practices so quickly as the adoption of telehealth during COVID. So we can do it. We can get the provider community to move quickly. Well,
there's some encouraging words for policymakers, and certainly at Virta Health, we're looking at this closely as well, since we are a provider and we delivered virtual care since day one when we started 2015. Well, let's stay in the kind of policy making arena a little bit, but I will ask this from Dr. Fleischman first. I guess one of the more significant recent changes to the regulatory landscape was the passing of what's called the Inflation Reduction Act. Could you, starting from Dr. Fleischman, could you please speak to if there are any implications of that act for care delivery from a health plan or health system or care delivery organization perspective? What's your take? And then we'll go to Dr. Hughes as well.
Yeah, I think for our members, for the members of Blue Shield of California, and actually for all Americans, this is a really important act for two really practical reasons. The first was the extension of the tax credits, which allows people to actually have insurance to buy into the marketplace. We consider, insurance is necessary but not sufficient for good care. But without insurance, without bringing everyone into the tent, we can't even start to change the health of Americans. So that piece was really important. And secondly, just the opportunity to lower drug prices for our members. We would have liked to see it broader, in particular around insulin, but we got what we got, and it's a start. And so our members having to pay less out of pocket is huge. I mean, we hear from our members that they are struggling, even with insurance sometimes, with the cost of medications. And so, families have to make decisions between what they're going to pay for. And sometimes it is food on the table versus medication. And so we don't want our members in that situation. So this is a step in the right direction.
Yeah, that's a scary sounding but true quote. Food on the table or medications. I wish nobody ever was facing that. Dr. Hughes, any comments from your perspective? How should healthcare leaders be thinking about this act?
Yeah, we're excited, and I think not to fully quote Vice President Biden, but this certainly is a big deal. I think everyone recalls his full quote. We won't say that here. But I think in terms of, for us, when we think back of our first 10 years at the Innovation Center, one of our models, the Part D senior savings model, is particularly relevant to this question. Through that model, our Medicare beneficiaries were able to pay $35 a month for their insulin, for the insulin supplies. And through the IRA, the Congress picked up this model, if you will, and made it available to all Medicare beneficiaries, not just those, not limited to those that were participating in our model. And I think they did that because they saw, to Dr. Fleischman's point, how important it was for Medicare beneficiaries, how well they participated, how well it was regarded, how well we were able to work together with manufacturers. And so we're excited, certainly in the context of what we're discussing today in diabetes, just how important a provision that was. And we at the CMS Innovation Center are also working very closely with our colleagues in Medicare to fully implement this law. And we also are starting to think about, are there additional steps that we might want to take in the CMS Innovation Center? But I think our full focus is certainly in terms of implementing this landmark law. How are we working together with our colleagues in Center Medicare? And in particular, insulin certainly is a focus.
Yeah, thank you both. Well, I have to jump on top of my own soapbox for a second. It is wonderful that insulin costs and copays are capped, but I like to say that what's better than low cost insulin for type 2 diabetes? There's one thing that's better, and that's not needing insulin at all. And so reversing type 2 diabetes and eliminating the need for insulin as a consequence, obviously, is one of the things we do at Virta Health. But okay, I'm gonna get off my soapbox. So let's talk about a little bit about chronic disease. So actually reversing chronic disease through new care models, which is actually the first full session after your keynote. But let's start from Dr. Fleischman. What are the chronic conditions that Blue Shield of California is particularly focused on right now, and what are your goals in treating, or outcomes goals for these chronic conditions?
So diabetes is actually on the top of our list. So this is very timely. We take care of 250,000 diabetics out of a membership of about 4.8 million people. So it's a lot of people. They have various payers, various benefits. They get their care all over our network, all over the state of California. Our goal is, to start by making sure that everyone is getting the right care, that they're even getting their hemoglobin A1C measured, that hemoglobin A1C is controlled, that they're getting their eyes checked, that they're getting their kidneys checked, that they're getting their lipids checked. I mean, again, to my opening comments, these are things that we knew we needed to do 30 years ago. The second part is obviously education, member engagement, and as a plan chief medical officer, I think about that two ways. What can we do directly as Blue Shield of California with our members? And then the bigger lever is what can we do through our providers? And in this way, I think Dr. Hughes, we're in the same place of, what are the levers to get the providers on the ground to do the right thing on member engagement. But I think, Sami, as you know, it takes more than education. Behavior change is more complicated than that. So we'll need to tackle that as well. But first of all, just getting the right care, these things that we've known about for so many years still don't happen across the board for Americans with diabetes. Our second area of focus in chronic disease will be people with multiple chronic conditions, complex longitudinal care. It doesn't serve those people to be in a diabetes program and a heart failure program and a hypertension program. How do we think of them holistically as having multiple chronic conditions? And on top of that, frequently social determinants of health may come into play. And so what does longitudinal care over time look like for those members? How much is in a brick and mortar office? How much can be at home? How much can be virtual, and like what that care model ought to look like. So we're spending a lot of time thinking about that.
Yeah, there was one thing you mentioned that you don't want to be looking at all these things separately. I like to say internally that we treat humans, not conditions. So you don't want to be, you want to be looking at the patient, the human, the whole health. First and foremost. Well, kind of staying in this theme of addressing chronic disease, Dr. Hughes, I'm going to take a little bit different angle here, which is that at least from a publicly available sources, it seems like CMMI has taken a more kind of a integrated models approach versus specific individual chronic diseases. So how do you think of diabetes in that context, given type 2 diabetes? I think the cost of diabetes is now around $400 billion a year in America, which is kind of mind-blowingly large sum. So how do you think of addressing something like diabetes, which alone as one chronic disease is massively negatively impactful and costly? How does that fit into your strategy of looking at larger integrated models for cost control and outcomes?
Yeah, that's such an important point. As we look back over our models, and we have supported over 50 models, we're currently operating 28 different models, was thinking that we didn't necessarily want to do disease by disease, condition by condition. We did want to take a more holistic approach. But that being said, we do have a number of disease-specific models, including one focused on diabetes. And so we're not stripping away areas of focus that we have already invested in. So for diabetes, it's also relevant. We have a substantial investment in a number of kidney models. We have focused on cardiovascular health. I mean, and all of those, of course, have relevance to our beneficiaries who have diabetes. But that being said, in addition to our specific areas of focus, we are trying to look across how can we better coordinate and integrate care so that our primary care providers can provide better care regardless of the conditions that you have, that our primary care providers can also integrate better with the specialists that certainly are needed for many individuals with diabetes and a host of other conditions. How can we make it easier? When we look back, I mean, it's a staggering number of how many doctors every patient has to see, how many chronic conditions they have to manage. As one stat that I personally resonated with me is that in 2000, every primary care provider had to coordinate with 52 different physicians across their patient panel. And that nearly doubled to 95 physicians by 2019. That was an 83% increase. And so how do we help the individual doctors manage care for their patients across their patient panels? How do we help the patients themselves? We have 70% of our Medicare beneficiaries have at least 2 chronic conditions that they have to have treated, help manage. And so it's just a really important area of focus. And I'm so glad you're asking these questions.
Yeah, so I think we have time for one more question before I'll then finish off by asking if you have advice for the listeners over the next 2 days. But the one question I'm going to ask you both is, it was super exciting that I think it was 2 weeks ago now, White House had this conference on hunger, nutrition, and health. And we were delighted to participate. And of course, in many ways, it was exciting for us because it was sort of a broad statement that, hey, we need to think about nutrition as a tool, if not the tool, addressing chronic diseases. And, you know, the flip side of the coin is the hunger. And we're super excited to participate. A question to you both. What practical things do you think will come out of that, either in your organization or more broadly in the United States? Like, what are you now working on as a result of that conference, if anything? And maybe we'll start from Dr. Hughes, because there was, I think, a specific ask for CMS, but around MDPP. But I'm just curious of your thoughts. What were your takeaways from that conference, and what's happening next?
Yeah, it was such an important conference to just focus on so many critical themes. The first, in terms of specifically within the context of diabetes, we at CMS have signaled that we are starting to think about what is the diabetes strategy, not just for the CMS Innovation Center, but across all of CMS. What is the role of Medicare? What is the role of our colleagues in Medicaid? Those that are involved in the marketplaces, and certainly our colleagues in the Centers for Clinical Standards and Quality. We have so many different authorities and resources and just amazing individuals with expertise in this area that we're all starting to pull together to think about what can our diabetes strategy be so that we can improve quality, increase access, and reduce costs. In addition, though, you mentioned nutrition. And I also think on a parallel, but very much related effort, we're seeing a much more intentionality around screening and making referrals. Our beneficiaries who may have food insecurity as well as other social needs. And so how do we better, again, treat our patients more holistically, acknowledging their clinical needs as well as these non-clinical or health-related social needs, as we sometimes call them. And that, too, requires partnering with some of our other agency partners, for example, in the Agency for Community Living and the area agencies on aging. Like how can we work better with those that have been addressing social needs and have a bigger footprint on the ground for decades as we kind of move forward in what for CMS is in some way a new world, if you will. So we're very excited about both directives and encouragement coming out of that conference in terms of what we need to focus on in the months ahead.
Thank you. How about Dr. Fleischman? Any takeaways for you or your organization from that conference?
Yeah, I mean, I think, one of I call it the elephant in the room a little bit on nutrition is that we all live in a pretty toxic food environment that we actually have created as a country. And so I think that help with nutrition is really helpful for our members, and we offer that education, member engagement. But as I said before, it really requires behavior change tools to get people to really change what they're eating. Even if they, if they live in a food desert, they don't have so many choices. But for our members who don't live in a food desert. It's still, I think, as you know, really hard to make those behavior changes. But I think it's a good start, and I think we need to kind of start to change the environment because it's really an uphill battle otherwise.
I could not agree more. And even with the best nutrition protocols, obviously, unless people can follow and get the support, is nothing will work. And obviously, that's what we've been working on at Virta Health. I am looking at the timer, which tells me that it's time to say thank you so much. Thank you so much for joining and sharing your insights. But most importantly, thank you for the work that you're doing for the benefit of beneficiaries nationally, and then of course the 4 million plus Blue Shield of California members in California by Dr. Fleischman. So thank you so much for all that work that you do, and thank you for joining. For listeners, I think we're going to take a 1 minute or 2 minute break, and then we'll move into the first actual panel conversations around chronic disease and new care delivery models. So hold on tight. I think we'll take a 1 or 2 minute break, and then we'll come back. But thank you again, Dr. Hughes and Fleischman. That was fantastic.
Thank you. Thank you so much.
Thank you.